So the landscape of treatments for EGFR exon 20 insertions is changing quite quickly, certainly within the US and shortly within the UK as well. In the US, they've had approval for Amivantamab recently, an accelerated approval. And Amivantamab is a bispecific bispecific antibody targeting EGFR and MET, and that data supporting it is from cohort expansion of the CHRYSALIS study. Now, the drug has to be given intravenously and is associated with some EGFR adverse events, typically cutaneous toxicities and nail toxicities, but also because the MET component has adverse events with hyperalbuminemia and peripheral edema. The bigger news is that the FDA also recently approved under accelerated approval Mobocertinib, which is backed up by the data from the EXCLAIM trial. Here in the post-platinum extension cohort, Takeda and investigators had demonstrated activity both in terms of response rates and in progression-free survival in platinum-pretreated patients. Again, this is EGFR exon 20 specific drug, so it doesn't have MET targeting activity, but it is EGFR targeting. So it does have adverse events with skin, nausea, and potentially with liver, and diarrhea is an ongoing challenge with this class of drugs. We've seen similar challenges previously with Poziotinib on the once-daily dosing from the Zenith ongoing phase 1 study with cohort expansions, and that has been really difficult to tolerate in terms of high frequency of dose reductions and discontinuations because of adverse events. We're very much looking forward to twice-daily dosing efficacy safety data from Poziotinib, because the PK may show that it's much easier to tolerate at that dosing schedule and therefore may have efficacy. So I think in terms of the UK, we need to be very mindful that we are going to have hopefully rapid access to Amivantamab and Mobocertinib in either a formal pre-license scheme or an accelerated license given a potential accelerated Project Orbis approval, but also both drugs may well be available on a compassionate use basis from the manufacturers. The key issue for the UK audience is identifying EGFR exon 20 insertion patients in the first place. NGS is really not very commonly used in the UK, although its use is increasing, and NGS is the gold standard for picking up patients with EGFR exon 20 insertion. We know that PCR-based technologies like COBAS, which is very commonly used, miss up to 30-40% of EGFR exon 20 insertions. And indeed, we know that some proximal EGFR exon 20 insertions are beautifully sensitive to the first, second, and even third generation drugs that we routinely use and are not exon 20 specific. So identifying the patient, having the right drug for the right genotype is absolutely key. And there are plenty of trials ongoing in this space in the UK, and ensuring that our patients have access to these trials both in the relapse setting and in the frontline setting is key strategy.